Here we go. It's a great pleasure to have you all here today. We're going to have Susan, Sohail, and Julia delivering presentations on previous VMR episodes. It's a great pleasure to have them all with us here today. For those who don't know me, I'm Mariana. I'm one of the Zip Silver's team members, and I'm very excited to be here today. So we're going to start with Salsan. Salsan, do you want to introduce yourself, and then you can go ahead and share your screen to start your presentation?
Yes, sure. Hi, everyone. I am Sosan. I'm a medical graduate from Jordan, and I am very happy to be here and to share my presentation with you all. And I hope you enjoy it. So I'll share my screen. Can you all see my screen? Okay. So the topic of my presentation is From Breathless to Breakthrough, Diagnosing Thrombosis Unveiled by Malignancy. This is a case that was presented by Ethan on July 24th, and the case was discussed by Dr. Robbie and Prof. Rez. Let's have an overview of the case. We had a 59-year-old female who presents complaining of shortness of breath and abdominal pain of acute onset. And on examination, she had diffuse abdominal tenderness and mild lower extremity edema. And her labs showed thrombocytopenia and markers of hemolysis. And on imaging, she had multiple venous thrombosis and negative thrombophilia workup. And eventually, she was diagnosed with hepatocellular carcinoma. So whenever we approach a case, we have to answer the 4 W's, which are the who, when, why, and what. And of course, the never miss features. So we started our case with a question by Dr. Robbie, which was, how does the shortness of breath merge with the abdominal pain, given the patient's chief complaint? So is it a thoracic problem that is being referred to the abdomen, or is it an abdominal problem that is being referred to the thorax? And while walking through the diagnosis, the case and collecting more data on the like having more labs and imaging, we found that the patient had elevated D-dimer, she had thrombocytopenia, markers of hemolysis, and the evidence of thrombosis. And Prof. Rez shared with us a couple of pearls from the labs. Due to the discrepancy of the patient's like the patient had normal hemoglobin levels while having markers of hemolysis. So Prof. Rez raised a question, which was, can we have normal hemoglobin and low haptoglobin in hemolysis? And the answer is yes. If the patient was dehydrated and the blood is concentrated and the patient has a good reticulocytosis response. And the second pearl that he shared with us is that, can we have low haptoglobin without hemolysis? And the answer was yes, in cases of cirrhosis. So as we were moving through the case with the labs and imaging findings, we found the term congestion, basically, which was the answer for Dr. Robbie's question, and we localized the problem to her blood vessels. And so our patient is currently having an acute chest, abdomen, and pelvis syndrome, and she had a MAHA-like picture. And whenever we have a microangiopathic hemolytic anemia-like picture, we have to think of common diagnoses like DIC, TTP, and HUS. In our case, TTP and HUS were less likely, but DIC was a presumable diagnosis. And another pearl that was shared by Prof. Rez is that he said that once a hematologist from Johns Hopkins said that one schistocyte in the right context is one schistocyte too many. And this emphasizes the importance and our role as physicians and our clinical judgment. And the course of our patient, she kept on having thrombosis, and she developed a stroke during her hospital stay. And now our patient has a ultra hypercoagulable state, which is defined as having atypical venous thromboembolism, having arterial thrombosis, and clotting on anticoagulant. And a common cause for this state or this condition is cancer. Other causes are vasculitis, APLS, PNH, and MPN. And whenever we have an ultra hypercoagulable disease or condition, we have to think of occult causes like cancer and seronegative APLS. And as walking through the diagnosis, APLS was on our differentials. And what is APLS? APLS is a thrombotic disorder with antibodies to phospholipids, and it affects middle-aged people with equal prevalence among females and males, and it is usually associated with SLE. And of the clinical features of this disease is having thrombosis affecting the veins, capillaries, arteries, with other manifestations like hematological, for example, having low platelets and hemolysis, as in our case, having pregnancy-related problems like recurrent pregnancy loss and preeclampsia. Our patient had a history of one spontaneous abortion, but this does not fit the criteria of recurrent pregnancy loss. Although the patient's workup for APLS was negative, we kept it on our differentials as APLS has seronegative subtypes. The other differential was HIT, which is heparin-induced thrombocytopenia. And we also learned that a person can develop spontaneous HIT as our body produces heparin naturally. So there is a chance of having HIT done. So now what the problem was that, okay, we have a patient who is clotting, but we were unable to identify the cause behind that. So in general, what is our approach for determining the cause of a clot? The first thing is to ask ourselves, is it acquired? Is it provoked? Do we have an underlying risk factor or a trigger for that? If not, should we consider inheritable conditions? For example, we have a young patient, or the patient is having recurrent thrombosis, if the patient is having thrombosis in atypical sites, if the patient developed warfarin-induced skin necrosis, and so on. And we usually do the thrombophilia workup for the common causes, for example, factor V Leiden, prothrombin gene mutation. And the third thing to ask ourselves is, should we be looking for undiagnosed malignancy? And this will move us to the topic of my presentation for today, which is malignancy and malignancy considered a hypercoagulable state. And now I have a question for the audience, is why do you think malignancy is considered a hypercoagulable state? If anyone would like to answer or like type in the chat. So for the sake of time, I'll be, yes, Shire said increase in inflammation. It's part of the pathogenesis. One of the causes is by secreting the inflammatory cytokines, it could cause the hypercoagulable state. Okay, so in general, the pathogenesis behind thrombosis, as we know, virtuous triad, which includes endothelial injury, hypercoagulability, and stasis. And in cases of thrombosis and malignancy, we can divide the causes or the factors related to that to patient-related factors, treatment-related factors, and the cancer itself. For patient-related factors, for example, the patient's age, if the patient has any other comorbidities, that puts him at a higher risk for thrombosis. And the second is the treatment. For example, certain chemotherapeutic agents increase the risk of thrombosis. For example, platinum-based chemotherapies like cisplatin. We have asparaginase also. Hormonal therapy like tamoxifen, and other immunomodulatory agents that puts the patient at increased risk. And it also can be iatrogenic, for example, from the central venous catheter. Okay, and now moving to the cancer-related cause. For example, the type of cancer, certain cancers are highly thrombogenic. For example, pancreatic tumors, GI malignancies, lung tumors are considered a very high risk for thrombosis. The stage and the grade of the tumor, the higher the stage, the higher the grade of the tumor, this puts the patient at increased risk for thrombosis. And the histology, like adenocarcinoma, has a higher risk for thrombosis than other types of tumors. And the mechanism also behind how cancer can cause thrombosis, we have some direct causes. For example, the procoagulants that are secreted by the tumors, like tissue factors, plasminogen activator inhibitors, and mucin secreting tumors, they usually interact with blood cells and resulting in the formation of microthrombi. So this is one of the causes. Other indirect causes like the inflammatory cytokines, they can cause endothelial dysfunction. The expression of adhesion molecules also increases the risk of thrombosis and the formation of microthrombi. And also tumor cells can generate a hypoxic microenvironment, which will also eventually contribute to the pathogenesis of thrombosis. So these are the mechanisms of cancer-associated thrombosis, the tissue factor, some anti-cancer treatment, and other causes like venous stasis due to the compression of blood vessels by prolonged immobility in critically ill cancer patients. And now, what are the types of cancer-associated thrombosis? We can have venous thrombosis, we can have arterial thrombosis, and we can have chronic DIC. For the arterial thrombosis, several tumors secrete thrombin and secrete vascular endothelial growth factors, which promote the platelet activation and coagulation. And cancer can cause a chronic DIC state, where it is less severe and has a more delayed onset of presentation, and it usually progresses gradually. And now, what is the difference between acute and chronic DIC? Acute DIC develops acutely, as the name implies, and where the blood is suddenly exposed to the tissue factor, and the compensatory hemostatic mechanism is overwhelmed. So we have the consumptive coagulopathy that ensues very early on, and hemorrhage happens, and early organ failure. However, on the other hand, chronic DIC is considered a compensated state, where the blood is either continuously or intermittently exposed to only small amounts of tissue factor. So the liver and the bone marrow are able to compensate by producing more coagulation factors and platelet. So in cases of chronic DIC, we have little obvious clinical or laboratory findings. And one of the most common laboratory findings in chronic DIC is elevated D-dimer, while the other parameters are usually within normal limits. And chronic DIC is mostly seen with solid tumors, and acute DIC is mostly seen with sepsis and trauma. Okay, and for now, we have a take-home message, which is in patients with unprovoked thromboembolism, as well as patients with arterial thrombosis without identifiable cardiovascular risk factors, this should always raise suspicion for occult malignancy. And as we've mentioned, some of the tumors are more likely to cause thrombosis, like pancreatic tumors, gynecologic, lung, and kidney. And now, what is the pattern of thrombosis in cancer? Does it differ from a non-cancer state? And the answer is yes, as cancer patients are far more likely to have bilateral thrombi, to have iliocaval thrombi, upper limb DVTs than non-cancer patients. And also we have other aberrant forms of thrombosis, for example, Budd-Chiari syndrome, the extrahepatic portal vein obstruction, and mesenteric vein thrombosis. And as we've mentioned, one of the factors contributing to thrombosis is treatment. And there is a predictive model for chemotherapy-associated venous thrombosis called the Corona score. I'm not sure if I'm pronouncing it correctly, but it involves the site of cancer. Certain tumors are categorized as very high risk, while others are only considered high risk. And it also involves the pre-chemotherapy platelet count and the pre-chemotherapy leukocyte count, the hemoglobin levels, and the BMI of the patient. And according to the risk, to the score, we have either low risk, intermediate, or high risk. And as we were coming to the end of the case and the diagnosis of hepatocellular carcinoma was made, Dr. Rabi raised an important point. He was like, is this patient having a tumor thrombus, or is it a bland, like a regular thrombosis? And the first thing I want to say is, what is tumor thrombus? A tumor thrombus is defined as a tumor extending into the vessel, typically a vein, and it usually occurs in a wide variety of malignancies. And it is also vital to distinguish a tumor thrombus from a bland thrombus in the setting of neoplasia, as the treatment and the staging will differ. And the pathology behind the tumor thrombus, as it is composed of soft tissue component and a thrombotic component. And the etiology, it is most frequently seen with renal cell carcinoma. However, it is also seen with hepatocellular carcinoma, with Wilms tumor, with adrenal cortical carcinoma, with retroperitoneal tumors, and transitional cell carcinoma. And there are specific or special, let's say, radiographic features that can be seen using ultrasound, CTA, and MRI, angiography, and nuclear medicine. And after the end of the VMR, Ethan reviewed the patient's chart, and the imaging finding did suggest that the patient did have a tumor thrombus rather than an actual bland thrombus. And as we've said, that the treatment also it is vital to differentiate between having a tumor thrombus and a bland thrombus, as the treatment will differ. And we can see here, as in renal cell carcinoma, the treatment, we can do an nephrectomy. However, in hepatocellular carcinoma and the presence of a tumor thrombus, this gives surgical resection is rarely performed. So this is why we have to know if it is a tumor thrombus or a blunt thrombus. And those are my references. And thank you all for listening. And I hope you enjoyed my presentation.
Wow, thank you, Salsan, for this rich overview on thrombosis and also in thrombos in general caused by underlying cancer. Thank you very, very much. It was awesome. If you guys have any questions, you can drop in the chat. I'll be asking Salsan. And in the meantime, I would like to invite Sohail and pass the mic to him to start his presentation.
Thank you, Sausan. That was a really great presentation. I'm always humbled by all of the cases and all the learning that this organization brings. I I wanted to introduce myself. My name is Sohail. I'm a fourth year medical student, and today will be sort of a bread and butter case. But I think this pretty much, I think, most of you already know all this information, but I hopefully this presentation brings a very nice framework into thinking about one of the bread and butter conditions that I saw in the VMR. And this case was presented by Maddie. The case discussions were Prof. Rez and Dr. Rabi. Okay. So for the case itself, so we have a 41-year-old male brought in by ambulance in a wheelchair presenting with acute onset proximal and distal lower extremity weakness and elevated CK after cocaine use. So let's say that a patient comes into your office with weakness in muscles and you're suspecting neurologic weakness. What is your approach to workup for neurologic weakness? And before I ask this question and pose it to the audience, I would really like to differentiate true weakness versus weakness due to fatigue from other secondary conditions. And during the case, Prof. Raz mentioned how distinguishing these two is important because we want to make sure that what the patient means by weakness is what medically because weakness has a very specific definition. And that includes a decrease in the strength of muscles. And I think if I remember back to my neurologic rotation, there was 5 different strengths of muscles you can grade it based on their strength. And from 0 to 5. And by weakness, we mean anything but the full strength. And so now, if we have sort of elicited weakness, true weakness on physical exam, what is your approach to weakness? Does anyone have any thoughts? You can just drop it into the chat. Um, or you can unmute. Either one works. Okay. So I'll go through. Yes, thank you, David. From cortex to muscle, that's perfect. And sensory bladder abnormality, that was in fact discussed as well on the case presentation. And we were worried about, whenever there's bladder involvement, whether this is could be a cauda equina syndrome. But yeah, so the way I think about weakness is this was a very good schematic that I pulled from the Clinical Problem Solvers website, and this is only a portion of the diagram they show. But if we think about how the muscles are innervated, the signals, the nerve signals, start from the cortex down to the brainstem to the spinal cord, out through the spinal nerve, which then forms a bundle of peripheral nerves, which then innervates the muscle. So any lesion in this pathway can lead to weakness, right? Um, And what's amazing is you can often localize the weakness just from the physical exam. So you don't need a lab values or anything like that. For example, in the spinal nerve, usually if you have a radiculopathy, then it will most likely form or follow a dermatomyotome distribution. Peripheral nerve is really hard to elicit reflexes. And then for the neuromuscular junction, is usually fluctuating in weakness, like myasthenia gravis, which causes fatigue as the day goes on, or Lambert-Eaton myasthenic syndrome, which often improves with exercise. And then you can have a pathology in the muscle itself. And in the muscle is most probably or most commonly presents with proximal as well as distal weakness. And as you can see here, most of the pathologies can be formulated just from the physical exam, which I find really cool. Okay, so some more lab results for a patient. So, whenever we see this picture on the right, we think of a certain pathology, but I think it's fruitful to go through the lab values that we also had during the case. So the sodium was low, the potassium was mildly elevated, BUN was 52, creatinine was 6.3, anion gap, there was an anion gap. LDH was high, CK was high, ECG showed peak T waves, and then this characteristic finding, which I'll talk more about, but uh, whenever we see a brown colored urine, the differential is still pretty broad. It can be bilirubin in the urine, it can be true blood, it can be maybe not so true blood. And so the latter I will explain. And in fact, the not so true blood was sort of the diagnosis for this patient. So this patient ended up having rhabdomyolysis. Um, and so the learning objectives for this case is to really identify a framework for the etiologies, and then to explain each and every laboratory abnormality that you saw in the previous slide. And hopefully this will, again, give you a really good schematic for understanding how the pathogenesis of rhabdomyolysis occurs. So the etiologies, I like to divide it into three buckets. And when I first visited this topic, I was like etiologies for rhabdomyolysis, and I saw they give a whole list of etiologies. But I think these, I sort of categorize them into trauma, exertion, and then sort of the miscellaneous category: drugs, infections, and toxins. And this is very important because when we think of rhabdo, we classically think of a young male perhaps who exercised a lot and then suddenly developed dark urine and comes to the hospital. But that is not always the case. And in fact, there are many other common causes that we see in the ICU setting, in critically ill patients, and maybe not so critically ill patients that haven't even exercised. So here are some of the buckets, or here are some of the common causes for each bucket. So for trauma, direct mechanical trauma, the crush syndrome. So that's common, and most of us already know that. But anything that causes prolonged pressure. So this could it's good to think broadly about this. So for example, surgery, immobilization, compartment syndrome due to burn patients, or in patients that face trauma, and then electrical injury due to a lightning strike. It's one of the rare causes of rhabdomyolysis. But all of these should be considered in this bucket. And then exertion. It's really a demand and supply mismatch. And the way I like to think about it is just like the heart muscle, right? Whenever we have angina, we have low supply of blood compared to the demand. And so whenever you have a high demand compared to supply, you can get exertion. So it's not only just physical exertion, such as exercise. You can also increase exertion sort of through inherited disorders. And in this case, it means that the muscle does not have um, capability of full metabolism to supply muscles. And so you can characterize in a way inherited disorders as being a subcategory of exertion, even though it's not really physical exercise in the literal sense. And then seizures, when you have just constant muscle twitching. So that could be exertional as well. And then you have drugs, infections, toxins as the last category. There you go. So medication. So statin is a very commonly prescribed medications. I think it's like the top 5 medications prescribed in the U.S. or worldwide. Antipsychotics, and then drugs. Really anything, but stimulants is something that I want to emphasize here. And our patient, if we look back, used cocaine prior to coming into the hospital for this condition. And then infections, and I keep infections broad because when I looked at the list of infections that can cause rhabdomyolysis, it's anything. It can be viral, bacterial, fungi, anything. And so I think it's very important to keep a very broad differential for this, and it's just not, crush syndrome or exercise that can cause this condition. Okay, so now I wanted to present sort of a flow diagram that I created for the pathogenesis of rhabdo. Because I know I at least had a hard time keeping some of these laboratory abnormalities straight in my head. So the first inciting event is, let's start with the muscle injury, and then let's work our way down from there. So for muscle injury, so whenever you have muscle injury, you have all of these substances that are released in the blood. So uric acid, lactic acid, LDH, potassium phosphate, creatine kinase, and myoglobin. And you can actually directly measure each of these abnormalities in the blood. And so, you will find elevated levels of any of these substances. But really what's amazing is after this sort of elevated substances, these are what cause the downstream effects that we see in rhabdomyolysis. So, for example, lactic acid and uric acid can lead to the anion gap metabolic acidosis. Potassium can cause peak T waves, and if progresses, it can really lead to abnormalities in the ECG. Just the classic hyperkalemia findings. Phosphate binds to calcium, causes hypocalcemia, very similar to what we see in advanced renal disease. And then the myoglobin can cause a positive urine dipstick with no RBCs, and this is important because the urine dipsticks that measure the qualitative assessments of urine the way it measures blood is that it detects hemoglobin and myoglobin. And so anytime you have hemoglobin, myoglobin, the urine dipstick will be positive for blood, quote unquote, but there may not actually be blood present. And so you need like a urine sediment to really examine to see if there's any red blood cells. Let's see. So next is AKI, and this is an entire discussion. So one of the ways that AKI can happen is whenever you have muscle injury, the fluid then enters muscle, essentially third spaces out of the intravascular area. And so you can get hypovolemia, you can get AKI. You can also get shock. Some people with rhabdomyolysis in advanced stages can get shock. And I should have drawn an arrow from here to lactic acid and then creating and worsening the anion gap metabolic acidosis. But think it would have gotten too complicated, so I kept it as is. But an arrow from here to here is very plausible. And then you can also see. You can also get uric acid nephropathy leading to AKI. You can get calcium phosphate, which then deposits into the renal parenchyma, causing AKI. You can get myoglobin, which can cause pigment nephropathy. You can get myoglobin, which can release iron, cause reactive or lead to reactive oxygen species, a formation of ROSs through the Fenton reaction, and then that can cause an AKI. So there are multiple mechanisms by which AKI can occur here, and I'll talk more about that later. So does anyone know of any other conditions that present similarly to rhabdomyolysis? And this was actually presented on the case on the actual VMR. It was mentioned in passing. Yes, tumor lysis, yes. So You can think of tumor lysis as very, very similar to rhabdo, except the creatine kinase, because it's not a muscle injury, right? So you can literally replace the top with tumor lysis syndrome, and you can get the exact same like pathology, which I found pretty neat. So very similar look-alike conditions. Of course, completely different etiologies, but the pathogenesis is the same. Okay, so AKI mechanisms in rhabdomyolysis. So I'll just briefly go through this. So pre-renal AKI, you can get a hypovolemia, decreased glomerular perfusion. And then for intra-renal AKI, we can get uric acid, deposition of the uric acid in tubulars causing microtubular obstruction. Pigments can also cause microtubular obstruction. It can cause direct injury to the proximal tubular epithelial cells, like either directly or indirectly through the Fenton reaction. And then we can get these also lead to vasoconstriction and thus exacerbating the prerenal AKI, which can then progress to even intrarenal. And then for the postrenal AKI, you can get sort of macrotubular obstruction. So stones such as calcium phosphate, uric acid stones you're more at a higher risk factor for these conditions. Okay, so the initial laboratory studies. So CK, we all know, at least 5 times the upper limit of normal. And then the urinalysis. This is important because the myoglobin is not detected in about 50% of patients. So, and this is because the myoglobin has a short half-life and is rapidly cleared compared to the CK. So just be aware that in about half of patients, you won't find myoglobin in the urine. And then additional laboratory test studies. So CBC and CMP, the coag studies are important to assess for DIC because some of these constituents of the muscles that are released into the blood can activate the coagulation cascade. And then the blood gas to measure for the anion gap, EKGs to look for those peak T waves or those hyperkalemic signs, blood cultures to assess for infections as an etiology, and then a tox um, to um, to assess for other etiologies as well, such as cocaine use in our patient. Okay, so I wanted to end here. I'm open to questions, but hopefully this schematic was helpful in framing the problem of rhabdomyolysis.
Sophia, thank you very much. I really love your schema, and I think it's very, very, very helpful and educational. Thank you very much for your presentation. Um, so if you all have any questions, please drop into the chat. I'm gonna be aware for any questions. And then in the meantime, I would like to invite Julia to introduce herself and also to start her presentation.
Sure. I hope you guys see the screen. My name is Julia. I am a former medical student from Germany, Berlin, and I'm about to start my residency quite soon. And today I'm just honored and very excited to be involved in the VMR recap session today. So I did have a really hard time choosing a case because there were so many rich discussions, thanks to all of you, to be honest. But I have to admit I'm a little bit biased because I do have a special interest in nephrology. But despite that, the discussion that Prof. Raza and Dr. Rabi had last Friday really inspired me. Jerome presented the case that was really great because they reminded me on a very basic principle in medicine, but that we can really apply to anything, like to analyzing lab values, approaching presenting symptoms. And that's what I want to share with you today. So I'd love to talk about some polls and how like that easy tool can prevent us from going down any rabbit hole that might not be appropriate at this particular time point, or just save us sometimes in the future. But before we get started, if you have any questions, please type them in the chat. I'll try to answer them later on. So let's get started with the problem representation. We had a 47-year-old male. He presented with an acute onset of right-sided pleuritic chest pain and a 7-hour dyspnea on exertion. That was interestingly right after the landing of a flight. He had a non-productive cough and denied any fevers. No notable past medical history except of UTIs and STIs. You might notice like the little symbols in the corner, and that reveals like the hint what this presentation is about. So you can probably tell it's about time course is key. When you digest the information of the patient's presentation, probably it's striking that it's acute. But let's start thinking about why the acuity in that case is even more worrisome or alarming than maybe in any others. Yeah, I'll add, sorry, the exam, the hypertension, that we have an elevated GVD. On auscultation, we had a basilar Ranke and 2+ pitting edema. Don't want to hold that information from you guys. So looking at the time course, so it's acutely, but if we look at the patient, we really should focus on like what does he or she brings with him. So if it's a previously healthy individual, it does take an extreme deviation from baseline to take them to the emergency department, whereas in a chronically sick patient, where it's kind of smoldering diseases going on, just a small delta from the baseline can lead to very severe presenting symptoms. So that meaning we really have to worry about that patient. What does that mean now? So pretty much what you probably have in mind as well. So if it's a very acute, hyperacute process, it does require acute management. In our patient, the acuity, the pleuritic character of the pain, the plane ride he was on, that is very suggestive for pulmonary embolism. We were reminded on the VMR that there are several reasons for pleuritic chest pain. So we should not only focus on the pulmonary embolism, but also think about pneumothorax, pericarditis, pleuritis, or like any kind of effusions, whether they're autoimmune, related to cancers, drugs, infections, and lastly, pneumonia. So before we like anchor on our like first type 1 thinking of pulmonary embolism, we should really step back and think about and rule out all the other emergency causes. So if we have any alarm signs, we first need an EKG and a CT test if that's not suggestive for anything in particular. What I'm trying to emphasize here is really that we have to prioritize and adapt our diagnostic tools wisely, depending on the acuity. So say our patient was presenting with pain that's provocable on palpation, we probably have some time with our investigation. Before we jump in the results of our EKG and CT test, I wanted to focus a little bit on the very basic cardiology exam, which is the jugular venous pressure. So if we think about elevated GVP, it does translate into an increase in hydrostatic pressure. That means that in a comparison with like bilateral edema, our mind jumps to heart failure. And that is pretty much very often the case, like a 95%. But the key here again is time course. Generally, if we have an elevated GVP and it is more with edema, it's more subacute and not very acute, because in hyperacute heart failure, you would not expect leg edema. Whereas in our operation, we have an acute setting, so we should really think about our differential to volume overload, which would be pressure overload. So that can be due to internal or external blockage. So think about pulmonary embolism or pericardial effusion. To summarize, if you have a sudden onset of an acute hydrostatic pressure, think about thrombus over heart failure. But keep in mind, there are conditions where you have a volume overload that develop very quickly. But then you would have also a rapid drop in blood pressure, which is not the case in our patient. Little dive into JVD, because at least in Germany, we don't focus that much on it. So how we do it, it's just you put the patient on a 30-degree angle, take your ruler and measure the distance above the sternal notch. It should not be more than 3 centimeters. And also important, it should fall with inspiration, because with inspiration, we have a reduction in intrathoracic pressure, meaning we have an increased backflow to the right atrium and then a decrease in JVP. If that's not the case, we can think about, or that's called the Kussmaul sign, which meaning like kissing mouth, which is also a German thing. And that means if we do not have a decrease in JVD during inspiration, we can think about differentials like constrictive pericarditis or restrictive cardiomyopathy, half-breath, a severe tricuspid regurg, or a massive PE. Lastly, if you guys sometimes have like difficulties in finding the GVD, I was reminded on the venous pulse pressure that can really help you distinguish the arterial from the venous pulsation, which is more like soft, and you have this double undulation where you can see the A wave, so the atrial contraction, and also the V wave, which is the rapid filling. Also, you can provoke it and change it. So we talked about the respirophasic theme, so it declines with inspiration. You can also maybe increase it with abdominal compression or decrease the pulsation when you compress right below the internal jugular vein. So let's go back to our case. Our patient had a low albumin, hyperlipidemia, a low AT3, a creatinine of 1.4 with no prior values, BNP of 12.6, and positive anti-PLA2R receptor antibody. I'll dive in that a little bit later. They also took a UA, which confirmed a nephrotic range proteinuria, and the EKGs, which we wanted to look at right in the beginning, shows the sinus tag and the signs of LVH. A reminder for you guys as well, like you would expect the protein range or the protein excretion in adults to be around 150 milligram per day. And we talk about nephrotic range proteinuria if it's above 3.5 gram per day. If it's like around or below 3, that can still be from the tubular interstitial and not from the glomerulum. That's why the border is right there. CT imaging, interestingly, then showed occluded PA thrombosis, a subtotal occlusion of the IVC and right renal vein thrombosis. That smells like nephrotic syndrome, which is defined as hypoalbuminemia, edema, and also proteinuria above 3.5 gram per day. I'd love to dive in another interpretation, which we discussed on the VMR, which I thought fits well into my schema, focusing on time course. So we should really be careful with interpreting the BNP, because it can be falsely low. So we have a type 2 error. For example, if we have a hyperacute setting and the atrium is not stretched, because that is the origin of the natriuretic peptide, that could be that the BNP is still normal. Another reason would be, for example, also a mechanical one. If you have pericardial effusion, which could also be the case in our patient because of the volume overload, there's not enough room for the atrium to extend. Another chronic cause to have a type 2 error, looking at the NT-proBNP is a chronic one. So I've learned that in adipocytes, the natriuretic peptides get glycosylated and inactivated, meaning that in patients with obesity, we can have a lower levels of NT-proBNP, even up to 30 to 40%. So rounding up our patients and our differentials, so the acuity of the process and the elevated GFD, several thromboembolic events, and the edema kind of puts us in an extensive thromboembolic state, explaining everything. So the question is, what are our differentials for that? It could be due to hypoalbuminemia, so losing protein C, AT3, protein S. Either you have that focal and naming it nephrotic syndrome, then we would have our urine analysis positive. That's our case here. Or we have it in the vascular leak syndrome, which is more systemic lose of proteins. Also, we should think about the liver and also the GI tract with protein-losing enteropathies, but also broaden our differentials. So APLS can be a cause. Cancers, especially like pancreas, pulmo, meds, chronic inflammatory disease, or dehydration. So we kind of summarize it probably a nephrotic syndrome, or it meets the criteria for nephrotic syndrome. Ravi taught us again how we can kind of build a structure around nephrotic syndrome. So we have histologic types for primary nephrotic syndromes. That's mainly in adults membranous, especially if they do not have a diabetes. In 80%, they do have an antiphospholipid A2 receptor positivity. That's what our patients had. Minimal change is more often present in children, but the other differential would be in FSGS, so focal segmental glomerulosclerosis. Here we would more expect a moderate hypoalbuminemia and obesity. The fourth one, I kind of highlighted only in gray because it's often nephritic, the membranoproliferative one, and post-infected like IgA, glomerulonephritis. When we have primary causes, we also have secondary ones. So amyloidosis will be one, diabetes, viral infections like syphilis, Hep B, Hep C, HIV, or lupus. So the magic one about the membranous is that you generally need a biopsy to prove that it is the disease due to a nephrotic syndrome. However, in membranous, our anti-PLA2R receptor antibodies are sufficient for diagnosing a patient. To round it up, I wanted to tell you some interesting fact about primary membranous nephropathy. So it is a thickening of the glomerular basement due to subepithelial immune complex depositions. The nephrot or the proteinuria is very broad range, so it can be kind of subnephrotic, but it can also be more than 20 grams per day. Generally, you often see glucose in the urine with normal blood glucose levels due to tubular dysfunction. What I found interesting is that the blood pressure is generally normal and the GFR as well, which is characteristic for nephrotic syndromes. Our patient, or Prof. Raz, taught us as well, if we have only one lab value of creatinine, we can kind of assume that it's acute. If we do not have any signs of a small kidney in ultrasound, a secondary hyperparathyroidism, or a low EPO. So we assume in our patients we did have an AKI, which is generally rare, But in our patient, it does fit because one of the reasons could be renal vein thrombosis and renal infarction. Lastly, you should really think about checking or doing a cancer checkup, because in like up to a fifth of patients, we do have solid tumors. Interestingly, if patients are positive for anti-PLA2R receptor, the likelihood is decreased. Finally, I'd love to sum it up with my take-home points. So biologically, acute processes require acute treatment, but we have to kind of open up to really evaluate how the time course is. We should adapt our diagnostic tools wisely, so depending on that acuity. Focusing on the JVD, the sudden onset of acute hydrostatic pressure, we should think about pressure overload. So, for example, thrombus more than volume overload, like in heart failure. And BNP has its type 2 errors, and membranous is the one nephrotic syndrome that can be diagnosed with no biopsy. So time course is key, and it's worth diving into that and narrow down to your differential. These are my references, guys, and thank you so much for being here and discussing.
Thank you, Julia, for this amazing presentation, for the highlight of very, very important concepts. And I also would like to thank all of you for putting this all together to present it to us. And I just would like to say how amazed I am by your presentations and how intelligent all of you are, and how you can like present things straightforwardly and also with so much content and information. Thank you so very much for being here today. Thank you all for joining us. And if you have any other questions, you can write in the chat right now and I will ask our presenters. Let me see if I see any questions. Doesn't seem like we have questions, but yes, I just would like to thank all of you. And I wish you all an amazing Tuesday. See you tomorrow. Bye.